Good morning, everyone. And today our discussion topic of discussion is urinary stone disease or urolithiasis. Now, to tell you urolithiasis, maybe many of one of you are thinking that this is the again the same topic which you have done in internal medicine, and it is coming back in surgery. Um, like the main details of this thing, how they are formed, why they are formed, what are the type of stones is of course written in internal medicine in detail, but of course, like in this one, we are going to discuss uh, what you can say. I'm going to discuss the surgical management in this one more than what you can say the all the things which you have already gone through. So, as you can see over here, urolithiasis or urinary tract disease, it is an old disease, and of course it's a very common disease, and it is said that up to 10% of the population over their lifetime, they can have kidney not kidney but urological stones or urinary stones simply. Now what are the type of stones? Of course there are many types, and as you can see, the most common one are calcium stones or calcium phosphate stones, and then there is magnesium ammonium phosphate stone, uh, magnesium ammonium phosphate stone, like which is basically called as true white stone. There is infection stones, there is uric acid stones, there is cystine stones. uh, so these are all kind of stones which can present in the people. And out of these, by the way, the calcium, this one, and true white, um, this one, which is magnesium ammonium phosphate stone, they are visible on the plain radiography. Okay, but of course, like the other stones, because they cannot be seen on the plain radiography. So nowadays, the best test, or what you can say, which is done uh, in the patients, is basically CT scan. And non-contrast CT scans are basically, you can say, is becoming the gold standard as the first investigation to uh, what you can say, to check like either the patient is having any stone or not. Because of course, as I told you, you guys already have done this topic. So most of the patients, when they are presenting to the hospitals, they present with pain, and the pain which is so typical, like it radiates towards the glands in males, and glands and scrotum in males, and towards the labia in females. So uh, like the investigation of choice, I would say, is like CT scan, because on that one, basically uh, all the stones are visible, but there is just one exception. What you can say, there is crystalline stones which are excreted by indinavir. Indinavir is basically a antiretroviral medication, which though it can be given in other conditions as well, but AIDS patient is on indinavir, so they may have stones which cannot be even visible on CT scan. But the good thing that all the stones, the common stones, calcium infections or struvite or uric acid stones or cystine stones, they all are visible on CT scan. So uh, how they are formed, what is the reason of their form, like why they form. You can see over here, there are multiple reasons, uh, like many causes are there. One of the causes, hypercalciuria, which can be due to hyperparathyroidism or sarcoidosis, or overabsorption of calcium, idiopathic overabsorption, you can say. So one of the thing is this thing. You can see over here, hyperoxaluria is a condition in which like there is too much oxalate in the urine. Okay, and then there is many other reasons, like this is the thing, idiopathic hypercalciuria or secondary hypercalciuria. So there are different reasons, you can say, by which these stones are formed. And I think like you have gone through that. You can say like causes of hypercalciuria is like oxalate is a salt from oxalic acid. We know like if there is too much production of that thing in the body, of course, like there is too much oxalic acid present in the urine. So, or oxalate present in the urine. So, you can see over here formation of calcium stones. Oxalate, a major component of most stones. Some evidence suggests that it may have 10 times greater effect on the stone forming process than calcium. And since calcium and oxalate, they are continuously excreted by the kidney into the urine, so they can combine together and they can form calcium oxalate stones as well. So this thing, and then you will see like infection stone. Of course, like these are what you can say the people who have like high urinary pH, like alkaline, which is due to bacteria which are urea spreading bacteria. Okay, they result in ammonia production, and as you know, like these are basically magnesium ammonium phosphate stones. So they can precipitate, they can form stones right in the tract. And then there is uric acid stones, like again, as we know, uric acid is produced by purine and pyrimidines. So purine metabolism, like it releases uric acid, and there is hyperuricemia, uricuria in the urine, and simply due to that, they can be present in the urine, like the stones can form. So you can see like they are the only radiolucent urinary calculi. So of course, like they cannot be seen on the X-ray. So that's the reason CT scan is one of the thing. Okay, so now like they found a lot of what you can say factors which can produce stones. For example, they found multiple causes like deficiency of vitamin A is one of them. Okay, so dehydration is one of the thing, because of course whenever there is dehydration there is less water, so simply the solutes or the solutes will be more, and they can precipitate and they can combine together. And then there is one of the thing is like decreased urinary citrate. So what you can say, this is one of the thing, renal infection, as you see, like in urea spreading organisms, by urea spreading organisms, they can do hyperparathyroidism, of course, like the first thing which can result into calcium stones. So all these kind of stones are formed by this thing. Okay, so a very common stone is calcium oxalate stone. Okay, and one of the thing about calcium oxalate stones, if I will tell you, like calcium oxalate stones is like they are irregular in shape, and simply they can damage the mucosa, which can result into bleeding as well. And it's a very hard stone. Then there is calcium phosphate stones, also, like of course when calcium will combine with phosphate, it will become calcium phosphate. So like they are also the one. And calcium phosphate stones are often present with ammonium magnesium phosphate, or you can say the true white stone. So now remember, like as I told you before, you can see the alkaline, when the urine is alkaline, so there is high risk of forming this true white stone. So what happens is, of course, like when someone have infection, they have more alkaline nature, so they can have this thing. And they are like they are very large, you can see stones, and uh, they can be very very large as well. And the same thing is with uric acid stones, and the same thing is with cystine stones. Okay, cystine stones are, as you can see over here, um, cystine stones are the most uncommon one. They're not so common, right? And most of the time, they are formed in the people who have some inborn errors of metabolisms. And now, like they can form. And after that, there is one more stones that is called as xanthine stones, but that was not mentioned here because they are extremely rare. Just like you can say, very 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 few people they may have this thing, xanthine stones, right? So remember, calcium stones are the most common one, and xanthine stones are the least common one. Basically, cystine stones, because xanthine are extremely rare. So now, uh, like whenever someone has stones, what happens is basically they may cause obstruction, they may cause infection, and may cause renal damage. Okay, like very simple way, what you can say, to like obstruction. Of course, when the stone will be blocked over here, of course there will be, like, the urine cannot flow, and the kidney can have hydronephrosis. And infection, of course, like they can present with infection, they can damage the renal mucosa, even the kidneys, so it can result into bleeding as well. So see, obstruction, stone can cause infection, can cause obstruction. Obstruction can cause stone, and obstruction can cause infection. uh, and same thing, infection can cause obstruction, and infection can cause stone as well. So see, you can see, this is a circle, and any one of thing basically can lead to two different things, right? So this is important. So now, what are the symptoms, guys? Symptoms are simply, it could be asymptomatic, it could be symptomatic, and whenever there is symptom, of course the patient present with uh, renal colic. And as I told you, the features of renal colic or ureteric colic, um, like they start, the pain starts, and it radiates towards the glands or the scrotum in the males and labium in the females. And sometimes the pain can be very severe, sometimes the pain can be just like not too severe, and most of the time you can see over here the pain could be here, here, or here, or the pain could be like, these are the referred pain of the kidney and the ureters, and see, it is radiating towards the scrotum or the labia, right? So this is basically the pattern of the pain which can occur. And if the stone becomes large enough to obstruct an infundibulum, flank pain, recurrent infection, or persistent hematuria may result. So yes, so of course, like, the next symptom will be blood in the urine, or which we call as hematuria. So this hematuria can be microscopic or can be gross, right? So depending, like, of course, like from patient to patient. Now, uh, if there is, of course, um, infection, there could be pyuria, right? So this is the typical presentation of the patient. So on physical examination, of course, we examine the abdomen. If there is hydronephrosis, of course, like the mass can be felt. If the outflow obstruction is there, so of course maybe the bladder will be enlarged. If there is infection, so of course, like, the patient will present with fever and other signs of infection. So of course, like, then we go for investigations. So the first investigation, or the least interventional investigation, or the most common investigation, which is performed everywhere, of course, you will do the urine examination. In urine examination, of course, you have to uh, rule out the UTI. You will see hematuria. Maybe you can find a small pieces of stone. Of course, you can go for renal function testings, like testing creatinine and urea, and of course, you will go for to diagnose the stone. So, to diagnose the stone, we can do many investigations. We can go for ultrasonography. It can tell us either there is any hydronephrosis or not, or it can also show the stones. Okay, so ultrasonography can be done, very easily done. Okay, and very good to locate the stones easily. We can go for uh, X-ray KUB. KUB is basically kidney, ureter, and bladder. If you'll see these X-rays, see, you can see over here the stones, or here the stones, right? So of course, like, this is X-ray KUB, in which, like, they cover the kidney, ureter, and bladder, And as we know, the most common stones, which are calcium stones, they are visible on X-rays. More than 75% of the stones are calcium stones, so they can be easily, we can easily catch them on X-ray. So that thing is a very, very, very useful investigation. But as I told you, the best investigation is CT scan, because it can also catch the radiolucent stones. So um, KUB can be done, and CT scan can be done, intravenous urography can be done, and what is this? Of course, it can tell us like the exact site of the stone in the kidney. Okay, and of course, it is intravenous venous urography, so we give them some contrast to the patient, and then we take the images, right? So the significance, like this one, these are the few featured, like few films of IVU, intravenous urography, and you can see they are showing the calyces here, here, right? Even the bladder. Okay, so they like here, of course, like we can see the location of the stone easily. See this one. Uh, Again, this is IVUs done. Okay, and like this one, of course, will tell us what is the exact location of the stone. Okay, other than that, we can go for retrograde urography. Of course, like in this one, we can give the dye, and then we can take the films. Okay, but it is retrograde, so of course, like the dye is given, uh, you can see over here. This is the photographs of retrograde pylography. Okay, so CT scanning, it will show us the stones, even the radiolucent stones. You can see over here, CT scanning, and of course MRI can be done. So all these investigations can be done in the patient, and uh, all these ones will give us, of course, like the thing that if there is any stones or not, and if there is any stones, so where they are located. So now we will go for the management, and of course we have to talk about the surgical management of these patients. So let me tell you that you can see like upper tract stones will most commonly hang up during passage at the uretero-pelvic junction, that is the a narrow part, at the pelvic brim where the ureter crosses the iliac vessels, that is also narrow, and just outside of the bladder at the base of the broad ligament in women, or where the vas deferens cross the ureter in men, or within the intramural ureter at the uretrovesical junction. So these are the areas where the stones can get stuck. Now, basically, one of the thing is basically is conservative management. It's like all the stones which are less than half centimeter of size, they basically pass spontaneously. So in that case, of course, so see stone less than 5 millimeter in diameter, they generally pass by themselves, right? But stones which are 1 centimeter or above that, like the chances of them passing is very small. So that's why when the stone size is bigger, we cannot go for uh, conservative management. Okay, now different books, they give different type of course, like some of them are American books, some of them they are like UK books. So of course, like these are all studies which are combined together, and they gave us something. For example, some of the books they say up to 6 millimeter and things like this, but don't get confused. If you are around this figure, so you are fine. So like for example, the stones which are 7 millimeter or more, they are more likely to be impacted uh, in the ureters, right? So, and the story is different for the bladder stones, the story is different for the kidney stones. Okay, the sizes are a little different. Now, simply whenever the stones are more than 1 centimeter, we need some sort of intervention. Okay, so what kind of intervention is there? Um, First of all, if you will see over here, uric acid stones. Now, this is a type of stone which can be dissolved. And how it is dissolved? When we alkalinize the urine. So, what we do, we put the patient on potassium citrate. So, when we put the patient on potassium citrate, what happens is like it basically dissolve that stone. So you can say like this is one of a medical treatment which can be done in cases of stone, if it is uric acid stone. Then you can see dissolution of the cystine stones. Again, alkalization of the urine helps. So now see, anyone who have these two type of stones, they can be uh, dealt medically. But of course, like if the medical help is not working, then we will go for surgical management. So now, anyone who have obstruction, persistent infection despite antibiotics, uncontrollable pain, or impaired renal function, basically surgical intervention is very important. Okay, so now what we do is basically um, we go for uh, some sort of surgical intervention. Anuria with stones, the major treatment aim is to relieve obstruction, so retrograde to insert a ureter tube, for example, or we can go for surgery, or we can do percutaneous nephrostomy or open surgery, open surgical nephrostomy. Okay, percutaneous, you can say nephrostomy or nephrolithotomy is becoming very, very, very common these days, and a preferred one. So what they do is basically they put a needle under the ultrasound guidance. Okay, they put a needle, you can see the needle under the ultrasound guidance, so that you know where the needle is going. So under the ultrasound guidance, uh, what happens that they take it to the kidney, and they put a nephroscope as well. Okay, and by looking from nephroscope, they can what you can say, they can remove the stones. Okay, so sometimes that's when the stones are large, they basically break the stones and then take it piece by piece. So of course, like this is what you can say, done percutaneously. Sometimes you can say if the stone is very large, then what they do, they use a treatment called as extracorporeal shockwave lithotripsy, ESWL. So basically, these are the shocks which are delivered to the patient, not not like to the patient, but to the kidney, you can say. So due to these shocks, the big stones, they are broken down into small stones, and then they can be removed. So uh, the thing is that we have to take out the stone. Okay, so maybe it depends, like uh, it is can be removed if the stone is in the ureter. So of course we can remove it by ureteroscopy. If it's in the kidney, then we can do PCNL or percutaneous nephrolithotomy. And if the stone is too much large, we can use ESWL, which is extracorporeal shock wave lithotripsy. So now, um, basically, this one, uh, when the stone have a crystalline structure, so they give shock waves to basically break it down. Okay, a very useful thing. See, like a big stone, by after ESWL treatment, can be broken into small stones. So this is very important. What you can say, very interesting and very useful way we have to break down the stones. Very commonly used. But many of the times, when they do ESWL, so what happens, like the small stones can go and can block the ureter as well. Like if the stone is in the kidney, after breaking down, of course, they can go into the ureters and they can be stuck over there. So that's one of the thing, okay, which can occur. But of course, like that can be removed as well. But most of the stones which are broken small, if they are less than half centimeter, they are going to pass through the urine. So of course, like before starting this treatment, sometimes they do give some antibiotics as well, painkillers as well. Okay, so this thing can be done. I told you ureteroscopic remove stone removal. Like this is a ureteroscope, and they can remove the stone through that. This is what you can say a flexible ureteroscopy stone removal. Like this one is the flexible one. Of course, this is the rigid one. See the metal and see the like the bendable material. So that thing. One of the thing. This is the laparoscopic stone removal. Of course, like neo technique nowadays, we have laparoscope to perform surgeries, and nowadays it's very easy to do by a short and small incision. We can they like the surgeons can approach the kidneys or different organs. And also one of the option, which is the older option, is open surgery for stone as well, in which like they approach the kidney through a lumbar incision, and then they remove the stones and then they close the surgical site. So all these things are available. So the options which are available, there is ureteroscopic removal, there is PCNL, which is percutaneous nephrolithotomy, there is ESWL, extra shock wave lithotripsy, and then there is open surgery as well. So open surgery or laparoscopic surgery. So uh, this thing um, now you can see over here pylolithotomy. What is pylolithotomy, by the way? Pylolithotomy, um, when the stones are in renal pelvis. So what they do, like they make an incision, um, and and they approach that area and they remove the stone directly with by some forceps. Okay, so this thing is there. Extended pylolithotomy is there, and there is nephrolithotomy. Okay, so this one is basically nephrolithotomy. If you will see over here you can see like they just remove the stone easily, but in this one, extended pylolithotomy. But here, see how they're approaching. So basically, when the stones are in calyces, okay, so they make an incision in the renal parenchyma and they approach the renal pelvis from here. Okay, so this thing is there. So pylolithotomy is used when the stone is in the renal pelvis. Okay, and extended pylolithotomy is basically uh, they reach to up to the wall of the collecting system. Okay, and nephrolithotomy is when the stones are in the calyces and or they are branching in nature, then they make an incision in the parenchyma and then they can reach there. And you can see over here one of the thing is partial nephrectomy. For example, if there is a stone which cannot be removed by either way, then they remove that part of the kidney. So this is partial nephrectomy. These are some tools for lithotripsy, mechanical tools. What is lithotripsy? lithotripsy is like breaking down of the stones, right? So of course, like these are some medical, like mechanical tools which are used um, to break down stones so that they will become small, and then they, like that they can be removed. This is extra hydraulic lithotripsy. But nowadays, of course, like what they use is basically the best thing which they use these days is ESWL, extra shockwave lithotripsy. So these are all the treatments which are surgical treatments which are available for renal stones, and stones can be removed. Um, though there are complications of lithotripsy, as I told you, there are complications of ureteroscopy, like of course, like damage to the ureter can occur, infection can occur, hemorrhage can occur. Even lithotripsy have infection can occur. So, like one of the complication of PCNL, percutaneous nephrolithotomy, one of the complication is bleeding, and sometimes after ESWL they can make hematomas in the kidney due to bleeding. So of course, like hematomas, uh, uh, hematomas, of course, they are space occupying lesions, so the patient may have what you can say a second surgery to remove that if it is not going by way by itself. So these are all the treatments which are available. And if you want to remember the complications of surgery, so remember like three very important complications which are almost complication for any kind of surgery. One is hemorrhage or like bleeding, second is infection, and the third one is damage to the adjoining structures. And then there are complications for what you can say some specific complications to specific surgeries. So I hope you understand, and I will see you in the next lecture.